Hey there. So today we are going to talk about the two most common types of antidepressant medication, and those are our SSRIs and SNRIs. So let's get started. So first, let's begin with SSRIs, our selective serotonin reuptake inhibitors. So SSRIs are antidepressant medications, and they're used to treat a variety of psychiatric disorders. So these disorders include depression, which can either be major depressive disorder, MDD, or premenstrual dysphoric disorder, or PMDD, which is related to PMS. It can also be used, antidepressant is a bit of a misnomer in that antidepressants can also be used, and they're very commonly used, to treat anxiety disorders. So these anxiety disorders include generalized anxiety disorder, obsessive compulsive disorder, or OCD, panic disorders, phobias, and post-traumatic stress disorder, or PTSD. So anxiety disorders, of course, and major depressive disorder as well. For anything to be classified as a disorder, it has to interfere with your daily life. So everyone has a little bit of anxiety. It's just a natural part of being human. I have anxiety before I go in to take an exam, or even before I have to teach sometimes, because it's public speaking, you're in front of someone, but a little bit of anxiety is healthy because it gets you sort of psyched up to be able to do stuff. When anxiety or depression starts interfering with your daily living, whether it's interfering with your ability to hold down a job, interfering with your ability to interact with others, making it hard to leave your house, that's when medication like SSRIs or SNRIs are warranted. Now, SSRIs work by increasing the concentration of serotonin in the brain. Now, serotonin is a neurotransmitter, a chemical that works in the brain that influences mood and emotions. So obviously, you don't have to go too far into the pharmacology, but just know that there's this thing called the serotonin pathway in the brain. So serotonin naturally travels through the brain, and by flowing freely within the brain and passing between the synapses and the neurons in the brain, if it accumulates within the brain, that is a normal function of how the brain is supposed to be working. So it keeps your mood stabilized. It keeps you from not being too depressed. Now, the problem is sometimes the uptake of serotonin. So serotonin gets released by the neurotransmitters, and then it immediately gets reabsorbed as part of that serotonin pathway. So that reabsorption we call reuptake. So reabsorption is equal to reuptake. Now, someone with depression or anxiety might not have high enough serotonin levels in their brain. The serotonin's not sticking around between those neurons enough to cause any positive effect on mood or positive effect stopping anxiety. So what happens is if there's not enough serotonin built up within that serotonin pathway, people experience depression and anxiety, or indeed anxiety disorders. Now, what the SSRI does is it stops that serotonin from being reabsorbed into the neuron before it has a chance to act in the brain to influence mood. And I'll show you on the next slide. One thing to keep in mind with SSRIs is the dosing and choosing the right drug. It's not an exact science. The brain is an extraordinarily complex organ that we still don't completely understand today. So because of that, one SSRI might work for someone when another one doesn't work for someone else. It's just sort of the way it goes. Everyone's brain chemistry is different. Everyone's disorder is different and pretty much unique to them. Everyone's brain is wired in a specific way. So we have to be really careful mixing and matching selective serotonin reuptake inhibitors. That being said, dosing and choosing the right drug for SSRIs is essential. So they're often tapered up over weeks until the desired effect. So you can't start right at the top dosage of an SSRI. The body has to get used to it. So as tapering up, you look out for the desired effect within the patient, and that's usually better mood, lower anxiety. And when that is achieved, you stop increasing the dose. Now, if one SSRI doesn't work, the patient can discontinue it and try another SSRI because, as I said, everyone's different. So some SSRIs might work better in some people than others. So this is an example of the serotonin reuptake pathway. Again, you're not going to need to know this, but I think it's useful in understanding exactly how the drug works within the brain. So you've got the synapse, right, which is the connection between the two neurons, those brain cells, the postsynaptic cell and the presynaptic cell. And within that synapse, that's where the serotonin likes to hang out, right? So SSRIs block the uptake of serotonin, which increases the amount present in the synapse and magnifies its effects. So when there's not enough serotonin, the person's anxious and the person is depressed, or maybe both. The serotonin, we want to make sure it stays in the synapse so it can have a useful effect before it gets reabsorbed from the presynaptic cell to the postsynaptic cell. So that's where the SSRI comes in. So the serotonin gets reabsorbed through this little guy, the serotonin channel, right? So as serotonin gets released into the synapse, boop, goes right back through the serotonin channel before it has really any time to have a beneficial effect. What the SSRI does is it goes ahead and blocks that channel, and the serotonin can't get in there, right? The little serotonin particle can't get in through there because it's blocked. So what does that do? That increases the concentration of serotonin and helps improve mood and anxiety. So side effects of SSRIs. One of the reasons why SSRIs are such popular drugs is they have usually very few or very tolerable side effects. So they're often the first choice used for treating depression and anxiety. We do have some other options for treating depression and or anxiety disorders, but a lot of times they have a bit more side effects or a few more extreme side effects that are less than desirable. But as with any psychiatric medication, usually the top side effect is drowsiness, because that medication is working directly in the brain. Your brain is in charge of how you fall asleep, if you're drowsy or not. And because of that, drowsiness is a very, very common side effect of an antidepressant like an SSRI. Dizziness is also possible, dry mouth and nausea. A lot of times people can avoid nausea by just taking the SSRI with food. And the most common complaint probably with SSRIs is changes in sexual function. So unfortunately, the way that SSRIs work is they do work on sort of the pleasure centers in the brain, which makes sense, right? Because if you're working to ameliorate depression or anxiety, it's going to have to be related a bit, at least, to the processes in the brain that are involved in arousal and sexual satisfaction and libido. So people often report a decreased sex drive. They report decrease in being able to, or at least men, they cannot achieve orgasm. Same with women, cannot achieve orgasm. So a lot of times SSRIs are not as preferred in people, maybe younger people who are currently in relationships. However, again, as with any side effect, it doesn't affect everyone. And you can usually, if a person's having issues of sexual nature with a certain SSRI, they can usually switch to another one and see some sort of improvement. Now, we do have cautions with SSRIs. Do not start or discontinue suddenly. So you have to taper up, slowly increase the dose. And if you want to, say, take the person off of the SSRI, you have to slowly decrease the dose, because people can go through withdrawal symptoms or even overdose symptoms if you go up too quickly or go up too slowly. So it's usually on the course of weeks that they slowly increase or decrease the dose. Now, suicidal ideation or thoughts might increase for the first few weeks of an SSRI treatment. So we like to say to patients, you're going to feel worse before you get better, but just hang in there. SSRIs typically take 4 to 6 weeks to fully work as well. Sometimes with certain disorders, especially like your anxiety disorders like OCD, might take as long as 10 weeks of continuous therapy to start seeing an improvement in symptoms. So people sort of have to stick it out when they're first starting that SSRI regimen, and just know that they have to continue taking it regularly, even if they're not seeing an effect right away. Serotonin syndrome is also a potentially lethal syndrome that has to do with an overdose of serotonin. So if too much serotonin builds up in the synapse, right? If the dosage of the SSRI is too large, or if it's interacting with some other drug that's increasing its effect within the brain, that can cause this potentially lethal syndrome called serotonin syndrome, which is sort of like a serotonin overdose in the brain. It can lead to seizures, high fever, rash, very, very nasty condition. And that's yet another reason why we slowly increase the dosage of SSRIs to avoid the possibility and decrease the risk of a patient developing serotonin syndrome. And then there are many drug interactions with SSRIs, but I do want to point out this one that might appear on your exam. At least when I was talking with some other pharm techs, I know it appeared on their exam. St. John's wort is probably the worst herbal supplement on the market, and let me tell you why. And I am normally an advocate for herbal supplements, and I hate St. John's wort. So it comes from this flower right here, St. John's wort, very pretty flower. And that flower has some chemicals in them, which are used to treat mild depressive symptoms. They're used to support a more stable mood and often used by people who want a more natural, I shouldn't say cure for their depression, but a more natural treatment for depressive symptoms. The problem with St. John's wort is it interacts with just about every medication under the sun in a very bad way. So not only do you have to make sure that a person is not taking St. John's wort if they're taking an SSRI or indeed any other antidepressant, you have to make sure they're not taking it, because that puts them at increased risk for serotonin syndrome, that very, very nasty potential adverse effect that we just talked about. It also puts them at risk of the antidepressant medication or indeed other medications that they're taking simply not working. A great example of this is birth control. St. John's wort decreases substantially the effect of birth control. So a woman who's taking her birth control along with St. John's wort, she's going to need at least another method of contraception, because that birth control is not going to work if she's taking the St. John's wort with it. It completely nullifies the effect. And that is the last surprise you want to have if you are already depressed, is a sudden pregnancy that is unwanted. So just note, anytime you see St. John's wort in the exam and the PTCV, think drug interactions, and that will continue popping up, because just it interacts, as I said, with just about every drug, SSRIs and antidepressants included. So examples of SSRIs, they're very, very commonly prescribed drugs. I think one of my professors she said something along the lines of like, well, we should really put SSRIs in the water supply, considering how often they are prescribed. The dosage forms of SSRIs, well, they're all taken orally, so they're all taken by mouth, and they can come in tablets, capsules, and liquid solutions. And those liquid solutions are often very good for people who have problems swallowing medications. So our very, very common examples of SSRIs are citalopram or Celexa, escitalopram or Lexapro, fluoxetine, also known as Prozac, paroxetine or Paxil, and sertraline or Zoloft. And again, these SSRIs can be used to treat any number of depressive or anxiety disorders. Next, we move on to our serotonin norepinephrine reuptake inhibitors, or our SNRIs. Work very, very similarly to SSRIs, except they are antidepressant medications that treat a variety of depressive and anxiety disorders, as well as having some effects on chronic nerve pain. So a lot of times you can kill two birds with one stone by using an SNRI, say if a person is depressed, but they also have some chronic nerve pain. Many times you can also prescribe a patient with chronic nerve pain and depression an SNRI, and that might be the best choice for them, as opposed to an SSRI. Now, SNRIs work by increasing the concentration of serotonin and norepinephrine in the brain. So both serotonin and norepinephrine are neurotransmitters that play a role in mood regulation. So instead of just inhibiting the reuptake of serotonin like the SSRIs do, the SNRIs also work to inhibit the reuptake of norepinephrine. So, and as a result of that inhibition of the reuptake of norepinephrine as well as the serotonin, it just so happens that SNRIs work in the CNS, right? The central nervous system, which is your brain and spinal cord, for neuropathic pain, because norepinephrine acts upon those pain pathways in the brain as well as those mood pathways. So side effects and considerations for SNRIs, literally the same as for SSRIs, right? So don't start or discontinue suddenly. Suicidal ideation or thoughts may increase in SNRIs as SSRIs do. They take about 4 to 6 weeks to work, sometimes up to 10 weeks. Serotonin syndrome is also a risk, as well as St. John's wort and other interactions with supplements. So you always want to make sure the patient is not taking any supplements that you don't know about. And you always want to make sure to ask for supplements, vitamins, teas, what have you, that the patient might be taking. As they do with SSRIs, SNRIs are also tapered up over weeks until the desired effect is achieved. So in this case, it would be better mood, lower anxiety, even less pain. And if one SNRI doesn't work, a patient can also discontinue it and try another SNRI, or indeed another SSRI as well. Dosing of SNRIs also, you could note, is higher when treating chronic pain. You just need a little bit of a higher dosage if you're going to try and treat the pain. Side effects of SNRIs tend to be a little bit more varied than SSRIs, which makes sense, right? Because it's working on two neurotransmitters instead of just one. So nausea and vomiting are quite common, as well as dry mouth and drowsiness. Those changes in sexual function may be a bit more common with SNRIs as well. So that includes anything from reduced sexual desire, difficulty reaching orgasm, and erectile dysfunction. Loss of appetite, constipation, as well as insomnia and sleep disturbances, such as very vivid dreams, are also fairly common with SNRIs. Sometimes people like the vivid dreams, though, depends. And higher doses usually mean more side effects. So that's why it's, as always, very, very important to slowly taper up until we get the desired effect while mitigating the side effects. Well, desired effect with as few side effects as we can manage. And as I said, generally they have more side effects than the SSRIs. And sexual dysfunction might be more common in SSRIs, but it varies sometimes even by the patient. As I said, everyone's different. And our example of SNRIs are pretty easy to remember. There's Venlafaxine and Desvenlafaxine, otherwise known as Effexor and Pristiq, respectively. Venlafaxine includes tablets and capsules, and it's also used to treat nerve pain, specifically in diabetic neuropathy. So when nerves get damaged in patients who have diabetes, especially in like the feet and hands, venlafaxine can be quite useful in treating that kind of neuropathic pain that diabetic patients have to deal with. Desvenlafaxine isn't approved for treating nerve pain yet, but it's extremely similar to venlafaxine, and it's marketed as having fewer side effects. They're basically twin drugs. They're very, very similar structurally. So you get basically the same effect with venlafaxine as you do with desvenlafaxine, except maybe a lower incidence of side effects. And lastly, the best SNRI for nerve pain. So it works for both diabetic neuropathy and fibromyalgia. That would be duloxetine or Cymbalta. This is probably the most popular one of the SNRIs that I can think of that's normally prescribed for people. It comes in capsules. And like I said, it's probably the best SNRI for nerve pain. So if a patient is depressed or anxious and they also have that nerve pain from diabetic neuropathy or fibromyalgia, duloxetine may be the choice for them. Well, that just about covers our SSRIs and SNRIs. Again, let me know if you have any questions. Thank you.